Hello, everyone. My name is Rebecca Munnerlin. I am with Prisma Health with the Media Relations team, and we are so pleased that you're able to join us today to talk about the recent CDC alert about malaria, particularly in the southeastern United States. We have with us today Dr. Helmut Albrecht. He is an infectious diseases physician with Prisma Health here in Columbia. He is also the Hayward Gibbs Distinguished Professor of Internal Medicine at Prisma Health and University of South Carolina School of Medicine. So thank you again for joining us. I'm going to just get us started with a few questions and let Dr. Albrecht kind of take it away with what he can share with us. And if you would like to post some questions in the chat, feel free to do that, and I will pass this along to Dr. Albrecht toward the end of this interview. And I'm also trying to enable everyone to record this locally. So if you're not able to, you can ping me in the chat and I will try to hit that button again for you. And if for some reason you're not able to capture it, we are recording this also, so we should be able to provide you a copy as well. Okay, just to get us started, on Monday, the CDC issued an alert that malaria is considered a medical emergency and that anyone with symptoms should be urgently evaluated. So on the heels of some cases in Florida and Texas, malaria is a mosquito-borne disease carried by some particular species of mosquitoes. And I will ask Dr. Albrecht to tell us a little bit about what malaria is and what the symptoms are, and give us some tips also about how in our local communities we can help to prevent the spread of malaria with it being a mosquito-borne disease. I think we're all pretty used to dealing with mosquitoes and trying to prevent those from invading our daily lives, especially in the evening when it's actually cool enough to come out in South Carolina. So Dr. Albrecht, if you could get us started with telling us a little bit about what malaria is, take it away. Dr. Albrecht, I'm not getting your audio.
If I unmute myself, right?
Okay, there you are.
You should hear me now.
Yes, we hear you now.
Good to see you all, and not talking about COVID for a change, or monkeypox. Let's talk about malaria. It is an incredibly common disease around the world. There's about 250 million cases a year, and there's probably more than that. This is the diagnosed ones. And it causes more than 500,000 deaths per year. So CDC and DHEC will issue a similar alert in the next couple of days. It is a potentially serious disease. It's mostly if you're infected with a particular species, and if you're a pregnant woman, a non-immune traveler, or a child under 5 years of age. Most of us should get through this pretty well. The symptoms would include fever, chills, headache, muscle pain, overall fatigue, typically quite severe. It's not your regular headache because you hadn't had your coffee yet. You know something is clearly wrong there. Can have gastrointestinal, can have neurological symptoms, and can progress to a life-threatening disease that is mostly shows kidney failure, shows seizures, shows lack of responsiveness or coma. And again, pregnant women, not only the pregnant woman is at risk, but death of the unborn is not rare in that setting with severe malaria. So it is very common. Well, but now it's in the US. Well, we have about 2,000 cases a year in the US. But virtually all of those are imported, which means somebody travels to sub-Saharan Africa, gets infected with malaria, and then shows up here in one of our emergency rooms. But it's so common enough that most of us see this several times a year and are quite well prepared for this. What we are talking about is different. This is locally in the US acquired malaria. So the definition of that is no travel into a malaria area and more than 10 miles away from an airport. So not a mosquito that made it onto a plane, but an infected person comes here, and that's again fairly common, but it gets bitten by a local mosquito, and this mosquito then bites somebody else and therefore creates a local chain of transmission, which is very different than these 2,000 cases that are acquired abroad and are just imported here. And even these local transmission outbreaks are something that we sort of used to see fairly commonly. Between 1957 and 2003, when the last one of this was in Palm Beach County, we had about 63 outbreaks of malaria in the US. But we've just not had an outbreak of locally acquired transmission since 2003. So that we have now two, one in Texas, one in Florida with 4 cases that do not seem to be related, is enough to get our attention. Again, 20 years since the last outbreak. And therefore, it's not terribly new. It's not all that threatening to specialists, and other mosquito-borne diseases like chikungunya, dengue had cases in the southern states, but they also did not establish prolonged outbreaks. Neither did these outbreaks that happened before 2003 in the US. West Nile, however, which is now endemic here, also started as a local outbreak. And last year we had an outbreak with several severe cases, including a deadly case in Richland and Lexington of West Nile virus. So you don't want these diseases to become entrenched in your local mosquito population. And this is why it's noteworthy, and we need to react, and everybody needs to, if they see a case, react appropriately so that it doesn't lead to a spread in our local mosquito population. One thing to say about this particular strain that we were told is in all these 5 patients is called Plasmodium vivax. That can cause severe disease, but it's not nearly as deadly or threatening as other strains. If I see somebody with this particular malaria, I would expect that I can treat clearly 9 or more out of 10 patients in the outpatient setting. We have good treatments for this. We should know how to diagnose that, which is in this particular strain is actually more tricky than the treatment for it, but it's certainly not as threatening as some other malaria types can be. Maybe I'll stop here and sort of take questions for this.
Let's see. WSPA has posted a question. What is it like as a physician to get an alert like this? What does it change for you?
Not much, because we see returning travelers and we do similar things with that. What we do, we go through our treatment algorithms. We let people know that to include Florida and Texas and probably other southern states in our travel history. If we have a compatible disease, we make sure that we have enough tests on hand. There's rapid tests available now in the last 5 years that are much easier than to have an experienced lab person. You need that we have enough malaria medicines stocked for severe cases, that we touch base in a large healthcare system like Prisma Health, that we have all our ducks in a row in all of our hubs that we have, and we go over our algorithms and our treatment schemes. But for us, this would be nothing new. It's just awareness is, I think, what changes to us, that yes, after 20 years, it's good to know that an outbreak is happening again, and sort of brush up for all of my colleagues to understand what we're dealing with.
On that note, do you know if the cases that have been identified in Texas and Florida are of the same strain, and is the treatment adjusted to the particular strain, I suppose?
Yes, the treatment for this particular strain is different than, for instance, the more deadly strain, because unlike the very deadly strain that lives mostly in red blood cells and infects a whole lot more, this one, the tricky part of it is that it creates a latent dormitory in the liver of patients. So you need, in order to eradicate that after you've treated the acute disease, you need other treatment to eradicate that. Again, they're standard, but it's a little different. You need to know what you're doing, but I would expect every infectious disease and tropical medicine trained person to know this. We have current information that the strains that they found is Plasmodium vivax, and therefore we can adjust our thinking and our diagnostic scheme and our treatment for that. We would make the diagnosis, we would confirm that if we would see that here. But yes, that's what we've heard so far from the CDC, that all of these cases were this particular strain.
You mentioned at the top of the interview, you mentioned the common symptoms for malaria, and I was wondering if you would talk a little bit more about those. You did say that, you know, if someone is having these symptoms, they are more severe than something a person might typically expect with a more common illness. So I was wondering if you could talk about at what point a person should worry that perhaps their symptoms could be related to malaria, and what they should do next. Should they go to their family medicine physician, or should they go straight to the emergency room?
So, it's rare. We haven't had a case here. The likelihood that you will have malaria when you have any of these symptoms is relatively low. If they are severe enough and you had an exposure history that makes some sense, I would call the family medicine doctor first, whether they feel comfortable diagnosing and treating that, or whether they want to refer. Most of those can come to us in the outpatient setting, not in the emergency room. I would think the fever has certain characteristics. Every 3 to 4 days, depending on the species, these red cells that have these parasites fall apart, and then you get a fever bounce. It's sort of a cyclical fever. Every 3 to 4 days, you feel sicker and you develop a significant fever spike. If you don't have significant muscle and pain and headaches and significant fever, sit it out and think of whether this is something else. This is typically not subtle. If you have no symptoms, please don't show up in the emergency room just to be tested. There's no test for that. So use a little judgment. If you've been in Sarasota 2 weeks ago and spend a lot of time outside and now you have every 3 to 4 days fever, call me. Other than that, see if your family medicine or internal medicine primary care doc can figure this out without me.
Good advice. Thank you so much. And it's good to hear that there's a bit of a timeline that you should be able, to have time to speak to your regular physician about what you're experiencing before you go to that extreme. Let's talk a little bit about prevention, if we can. How do you recommend to patients to repel mosquitoes? I know there's a lot of things that are available, over the counter, like your standard bug sprays, like personal bug repellents and things like that. And then also, I know we probably need to mention how to check around your personal property and dispose of standing water and take some common sense prevention methods that maybe deter the development of mosquitoes in your immediate environment.
So we're used to diseases mostly like West Nile that are transmitted by other mosquitoes. So this one runs a little bit different. First of all, we know that we have these mosquitoes here, like essentially any state in the continental US has that. The last large-scale assessment, we found that over 50% of our South Carolina counties here had malaria mosquitoes. And I think actually it's fair to say that 100% of counties in South Carolina should have these mosquitoes. I know I have them in my backyard, including the ones that transmit this quite nicely. That means we have the mosquitoes that can carry this, but we have, as far as we know, none that carry the malaria parasite currently, as far as we know. So if you decide to avoid mosquitoes or treat mosquitoes in your backyard, it's not for malaria, it's for nuisance things, and it's a good thing to not have standing water and to chlorinate water and those kind of things, but you can't completely avoid mosquitoes. Right now, the particular strain that we're worried about, it's different strains of Anopheles mosquitoes, they're called, are here, but they don't do anything to you other than annoy you and give you itchy bumps. So right now, you really don't have to do anything. Even if you have a pregnant wife at home or small children, unless you want to protect them from mosquitoes per se, but you shouldn't do that for malaria. If you want to repel mosquitoes, the CDC and DHEC recommendations stand. There are things you can buy candles and you can do certain lemon aromas and otherwise. They're just not effective enough. If you really mean it, you have to use something that has a chemical in this, which are known to be safe, but don't drink it, don't put it in your eyes. Have a certain concentration of, for instance, DEET is the most common, which is in several compounds in it that you can spray on or rub a cream on. Avoid times during the day. None of these mosquitoes can find humans because it's hotter outside than our body temperature is. So in the evening and in the early morning, you need to protect yourself, and everybody knows how to do that, either with spraying something on you and wearing long sleeves and checking your that the screens in your house are still functional. These particular mosquitoes do not dwell in houses as much as the ones, for instance, that transmit West Nile. So it's not as much of a threat that this becomes an ongoing problem as it is for other mosquitoes.
Thank you, Dr. Albrecht.
Sure that you wanted to hear.
Yeah. The CDC warning also did mention that fully 95% of malaria infections are acquired in Africa. So that goes to what you were saying, that most cases are imported, so to speak. So is there any other advice you would leave us with, or any other thoughts you may have just about the CDC warning in general and the warnings that the individual states are rolling out this week?
Yeah, I think knowing the strain, that this is not as threatening as it sounds initially, and it's not as new to us. We got this. This came in, I would probably be able to treat this with a couple tablets in the outpatient setting. It's not as new or just as threatening to specialists as the announcement seems to indicate, I think.
So really just this is an opportunity for awareness and some reassurance that it isn't quite as scary as it sounds right off the top of the warning.
No, and it's not unexpected for us to see these kind of things. People are traveling again. We're going to have more influx of people coming back from these countries where there's a lot more malaria. COVID has devastated some healthcare systems, not only because every priority was COVID, they've neglected other diseases. So we expect more of these things swapping back in. We had to worry about vaccinations, not about mosquito pools that much, even here in the US. And these are the fallouts of such epidemics that we expect, which happens for other diseases as well.
Good to know. Well, thank you again for Dr. Albrecht for just helping us understand what this means. And if I don't see any more questions from our media partners, so unless someone has one to slide in real quickly, I think we're going to conclude. Thank you again. And Dr. Albrecht, we know who to come to when we have questions about these types of alerts. That
maybe one more issue. Sorry to interrupt, but
no, good. Thank you.
There's no vaccine available for this particular strain here in the US. So you cannot run to your primary care docs to ask for a vaccine for this. It's not available here. There's several in development and some available in Africa, but not for this strain right now.
Good to know. Good to know. Okay, any other final thoughts?
That was it.
All right. Thank you, everyone. If you have trouble with your recording, just let me know and we'll be glad to share ours with you. We appreciate you, Dr. Albrecht, and our media partners for helping people understand about these day-to-day health topics that we are very pleased to be able to cover. Thank you so much.
Thanks for having me.
Bye-bye.